Assalamu alaikum. This paper is a case series that was done by a Chinese group about endodontic microsurgery of mandibular second molars using the Bony Lid approach. Apical surgery is a procedure to be done when non-surgical root canal treatment fail or when that procedure is not feasible to be done. One of these cases is the failure of root canal treatment of mandibular second molar. Due to their thick buccal bone and poor visibility and the potential of neurovascular complication, all of these factors make it quite challenging to do apical surgery to these kind of teeth. So this group applied this procedure of the Bony Lid approach with the aid of CBCT in 10 cases of endodontic microsurgery for mandibular second molars. The Bony Lid, or the bone window technique, is the use of a thin osteotomy instruments to cut and remove an intact cortical bony lid, which is acting like an autologous graft for the surgical site, and this piece will be repositioned to the original site at the end of the procedure. Also, they mentioned that this procedure will provide a better visibility of the operation field and it will minimize the bone loss. CBCT was used to precisely measure the thickness of the cortical bone in three-dimensional way and also to identify the location of the mandibular canal, which helped reduce the risk of complication. They presented 10 cases that was done between 2019 and 2020 in a VIP center in China. All these cases, they said, it showed complete healing at the 24th or 36th month follow-up. 9 cases out of 10 were diagnosed of previously root canal treated with symptomatic apical periodontitis, while one patient had a diagnosis of a combined perio-endo lesion. In their procedure, they mentioned administering a full thickness flap with one vertical release, and they made their bony lid of approximately 5 by 13 mm by making 2 parallel vertical and 2 parallel horizontal grooves on the plate using ultrasonic osteotome with piezo electrical saw. And after finishing the procedure and cleaning the surgical field, that bony block was repositioned at its original site. In 3 of those surgery, bone graft of bioos was placed in the bony defect with a membrane, and they were tightly wedged between the bony block and the window border, and that grafting material provided support and stability to the bony block. While in the 7 other cases, the inward beveled edge of the bony block facilitate its replacement to its original position without the need to stabilize it. One trick here is mentioned is to use the thinnest ultrasonic tip that was selected to ensure that the incision gap is to be as small as possible. In my opinion, I think this approach is a pretty good approach instead of extracting those teeth in case of failure. But also this procedure may require higher skills because it needs to remove that block in one piece and reposition that block again in its place in an area of low visibility and low accessibility. Also, I think this procedure will take longer time than normal apical surgeries because of its nature of trying to remove that bony lid in one piece and trying to fix that in its place in one piece also.